Welcome everybody to another Health Services Research Association webinar. I've lost count now of how many we've done, but it's turning into a regular occasion. So just to give a little bit of background to the association, we aim to support health services research in Australia and New Zealand, and these webinars have proven to be a popular meeting to present and discuss health services research. And just to note that all of the videos for the previous webinars can be accessed through the website. So please have a look at any webinars you may have missed, and you can view those in your leisure. We also do various other things. So we promote health services research through awards and prizes. And I just wanted to highlight the fact that we've got a call for nominations at the moment for a range of awards, including Best Research Paper, Best Policy Impact, and Best PhD paper. So please check the website for details on those awards. And later in the year, we'll be holding a more traditional face-to-face meeting to present the winners of those awards, but also to hold a more an event in which health services research is presented more broadly. And we're aiming to hold that at the National Press Club in Canberra to support direct engagement with media, but also with policymakers based in Canberra. So that's something we're quite excited about. So keep an eye out for that. We also support health service research through communication with governments and the health service. And recently we've been quite involved in putting submissions together to various consultation processes, including the Medical Research Future Fund, the Productivity Commission Data Review, the ARC Engagement and Impact Assessment Review, and they've all been submitted. The one outstanding one is the review of the NHMRC's grant programme, and we're putting a short survey up on our website to inform that submission. So that will be up by the end of the week. So if you get a chance, it would be great to get your thoughts on that consultation. We can then incorporate within our submission. Finally, our other main activity is a 2-yearly health services research conference, and the next conference will be in the Gold Coast in November next year. So still a little bit of a way off, but we'll be calling for abstracts in the first half of next year. So keep an eye out for that again on the website. So back to today, back to the webinar. Today we're welcoming Associate Professor Zachary Munn. Zach leads the educational program at the Joanna Briggs Institute. For those who don't know, the JBI is an internationally renowned research institute that specializes in the synthesis, transfer, and utilization of evidence. It was founded by Professor Alan Pearson, and it'll actually be 20 years old in November, I believe. So that's certainly a reason to celebrate. Zach himself has wide-ranging experience in systematic reviews, but also implementation projects, and that's what he's going to talk to us about today, focusing in particular on the use of audit and feedback to change and improve practice. So just in terms of housekeeping, we can't take verbal questions and comments, but you can use either the Q&A tab or the chat tab to type any thoughts or comments that you have as the presentation is ongoing, and then Sarah and myself will relay those questions and comments to Zach, either as he's going through, if it's an urgent point of clarification, but more likely at the end, and then Zach, we can get a discussion going. So on that note, I'll hand over to Zach. Thanks, Zach.
Thanks, John, and thanks, Sarah, as well, for inviting me to give this webinar today. And thank you all for joining online as well. So today I will be discussing a quick introduction to, hopefully my slides will move, to evidence-based healthcare, evidence implementation as well, covering off what evidence implementation is and strategies for evidence implementation. Then we will discuss in detail audit and feedback, and how audit and feedback can be used as a strategy for evidence implementation. And we'll finish up with some real-world examples of audit and feedback as an evidence implementation strategy. And then there should be some time for questions and answers at the end, but I'm also happy, as John said, to take urgent questions throughout the presentation as well. So obviously, to understand evidence implementation, it's first important to understand the concept of evidence-based healthcare. Most people and most health professionals and researchers are aware of evidence-based practice nowadays and may use it to inform practice, but it's always good to start right from the beginning with any presentation. So some of you may know this already, but a quick introduction to evidence-based healthcare. The term evidence-based medicine was first coined by a Canadian doctor called Dr. Gordon Guyatt, who worked at McMaster University in Canada, which is often considered the cradle for evidence-based healthcare. And the father, or the key leader in the early days of evidence-based medicine and healthcare was Professor David Sackett. And in 1996, Professor Sackett wrote an article in the British Medical Journal about what evidence-based medicine was and what it was not. And the definition that he provided in that article is the definition which is still used widely today to describe evidence-based medicine and evidence-based healthcare. So Sackett stressed the importance of using the evidence in evidence-based healthcare, but that the decisions that were being made were about the care of the individual patient. And he stressed the importance of integrating the research with clinical expertise, the best available external evidence from systematic research, and the conscientious, explicit, and judicious use of evidence. So what does this mean? Well, evidence-based healthcare can therefore be seen as being made up of 4 different components. Often, and in the early days of evidence-based medicine, it was critiqued as being a cookbook approach to practice, which slavishly followed the results of, say, randomized controlled trials to just research, and didn't incorporate client or patient preference, professional judgment or expertise, and your own context and the resources available to you. However, in that 1996 article, and since the early days of evidence-based healthcare, it has evolved to incorporate all of these various elements. So not just following exactly what the research evidence says, but being informed by that evidence and then considering it along with the individual patient in front of you and their preferences and concerns, your own expertise, and the context, your own context and resources. So this is just summing up these points. Now, evidence-based healthcare has evolved a lot over the last 20 years, and in the early days, the focus was on using the findings of randomized controlled trials, and those randomized controlled trials included in systematic reviews, to inform practice. Professor Alan Pearson, who was the founding director of the Joanna Briggs Institute 20 years ago, highlighted the importance of other questions as well, which to inform practice. So healthcare professionals and policy makers are not only interested in questions of effects, but also questions of appropriateness. Is this an appropriate treatment? What is the meaningfulness of this treatment, and whether it is feasible as well, given our context and setting. So Professor Pearson highlighted the importance of these other aspects of evidence-based healthcare as well. And he also highlighted the importance of the best available evidence. So the strict dogmatic view that randomized controlled trial should be the only evidence to inform practice doesn't help those where there is no randomized controlled trials, and certainly in particular fields where randomized controlled trials are often not conducted. People still need access to evidence to inform their decision making. So Professor Pearson highlighted the importance of the best available evidence to inform practice. Not only that, but he had a big focus on getting that information into the hands of those who determine health policy and who deliver healthcare, and actually implementing that evidence into practice. So some of the key principles underpinning evidence-based healthcare is that we know we need to use interventions that are supported by up-to-date evidence or knowledge, and use the best available evidence to support this. However, we also know that there are many difficulties faced by health professionals in keeping up to date with the literature and following what the literature says. So we know that in evidence-based healthcare, one of the key principles is that we need to provide practitioners with condensed information, which is often gathered through the systematic review of international evidence. And organisations such as the Joanna Briggs Institute, the Cochrane collaboration and the Campbell collaboration conduct these systematic reviews to provide that condensed information to healthcare professionals, researchers, and policy makers. I just wanted to quickly touch on the John and Briggs Institute, and John's given a good introduction to our work. We are a not-for-profit evidence-based research institute with our headquarters here in Adelaide. We were founded 20 years ago this year, so it's actually our 20th anniversary this year, and we're planning on a big celebration in November at the Wine Centre. If any of you are available, please come along to Adelaide, if not for the conference, then for the wines at the National Wine Centre. And what we do here at the John and Briggs Institute is focus on the synthesis, transfer and implementation of evidence into practice. And we are considered one of the global leaders in evidence-based healthcare. We also offer training and support for systematic reviews and evidence implementation projects. And this is just a quick snapshot of our collaboration. We started off in Adelaide, but we are now known worldwide and have collaborating centres and groups contributing to our work across the globe. So our vision is a world in which the best available evidence is used to inform decision-making at the point of care to improve health outcomes in communities globally. And over our 20 years, we've come up with this model of evidence-based healthcare, which informs everything we do here at the John and Briggs Institute. And I just want to quickly run through this model now before we focus on the last wedge of this model, evidence implementation, later on in the talk. Of course, at the centre of everything we do here at the John and Briggs Institute, the only thing we ever think about, dream about, discuss is evidence-based healthcare. And we consider evidence-based healthcare to be evidence-based or healthcare decision-making, which considers the feasibility, appropriateness, meaningfulness and effectiveness of healthcare treatments or interventions. Obviously, through following the principles of evidence-based healthcare, we want to have an impact on global health and improve global health as well. To do this, we need to make sure there is a process of engagement, engagement with researchers, with clinicians, with patients, and across academic and health service settings as well. So engagement at all levels is critical to adequately performing evidence-based healthcare. Through this engagement and collaboration, knowledge needs are identified, which then inform the conduct of research. So evidence is generated based on these knowledge needs, and this evidence could be in the form of research, expertise, or discourse. Now, there is a lot of research which is generated. We know that there is over 500,000 articles added each year to Medline alone, which is just one of the large medical databases. And it's just far too much evidence to consider. So this evidence needs to be synthesized, and this is often done in the with the conduct of a systematic review. And the systematic reviews, which many of you will be aware of, are a rigorous process which are based on the principles of research. It is a research process in itself, informed by a protocol which rigorously evaluates and critiques all of the literature, that's an important thing, on a certain research question. So once this evidence is synthesized, whether it be in a systematic review, an evidence summary or guideline, it needs to be transferred into practice. And there are ways to do this, to disseminate. Dissemination is one of these, both active and passive modes of dissemination. It needs to be integrated into systems, so policies and procedures, but also with clinical decision support systems if they are available, and education as well. And what we'll be focusing on today is evidence implementation. And at JBI, we see evidence implementation as perhaps the most important part of evidence-based healthcare, making sure that people are actually following what the research evidence says and making a change within their setting. And all of this feeds back, and this model is a cyclical model. So once we've implemented the evidence and evaluated it, there may be additional questions that emerge, which then need to be researched, synthesized, and transferred. For more information on our model, you can access the link here on this slide. So why do we need evidence-based healthcare? Well, we know that practice varies considerably, not just across health services and across health organisations, but even within organisations. And sometimes this is justifiable, but many times it isn't. So we know that's one of the reasons we need evidence-based healthcare. We also know that healthcare is becoming increasingly costly in both the developed and developing world, and evidence-based healthcare can address this. But most importantly, we want to make sure that our patients are being given treatments based on the best available evidence, with the aim of improving outcomes for our patients. However, the reality is that most organisations do not have evidence-based cultures, and there's been a lot of research investigating the compliance of different areas of healthcare, their compliance with what research or standards or the evidence says. Some recent research in Australia in primary care found that on average, and this is a gross average, only 50% of consultations for patients in primary care, and only 50% are patients actually receiving the most appropriate care, And across healthcare itself, compliance with standards and evidence-based healthcare varies widely, from around 11 to 82%. And it depends on what specialty you're working in, what field you're working in, what profession, etc. But either way, we know that it's not currently being performed in an ideal way, and we know that a lot of people are either getting treatments which aren't based on the best available evidence, or that are potentially harmful or perhaps wasteful as well, or not required. So this is a very large problem across all areas of healthcare. Why is this happening? Well, there's many barriers to evidence-based practice, and some of these are listed on this slide. Sometimes there's a perception that the information doesn't exist to answer questions that emerge. It can be difficult to find the time to find the research to answer a certain question. Research doesn't always address the evidence interests of clinicians or policymakers and may be coming from a more academic mindset. There are resource barriers to finding research, and this can take quite some time as well. Academic reports are not always accessible and presented in an accessible way to healthcare professionals. And healthcare professionals, and particularly policymakers as well, may have limited skills in accessing and appraising evidence. And what this leads to is the information paradox, where health professionals can be overwhelmed by the information provided for them, yet still can't find the information they need. This results in what we call the evidence practice gap, which is the gap between what the research suggests and what is actually occurring in practice. And this gap, there's different figures of just how long it takes to fill this or address this gap. But on average, we can say it takes about 17 years to get the findings of research into practice. And I'm sure many of you are familiar with the term knowledge translation, which essentially means the movement of research from one stage to the other, whether it's from bench to clinical to actual patient delivery or delivery of care. And knowledge translation is a growing field of study to address gaps in knowledge and the movement of research. So the traditional gaps in knowledge translation are the gaps between bench or discovery research, that done perhaps on research done in labs or animal studies, and the gap between this type of research and that research which is done in trials and human research. Now, the gap which we address mainly here at the John and Briggs Institute, and that perhaps evidence-based healthcare is most interested in, is the gaps between that human research and clinical policy and action, what's actually going on in practice. We've also proposed that there is another gap here as well, where there is an unmet need for knowledge which comes from key stakeholders such as practicing clinicians or the patients themselves, and that this gap needs to be addressed, and the knowledge needs of these groups need to inform the conduct of research. So what's been the traditional approach to the gaps and to changing practice? Well, essentially, once researchers complete their project or their study, they normally present these results at a conference and publish in peer-reviewed journals. And then the hope is that practice will change and that people will hear about these presentations, read the peer-reviewed publications, and then start changing their practice. However, we know this simplistic approach is not working, and that's why we've seen the low compliance with what the research says and this long time lag for getting research findings into practice. And this has also led to the field of evidence implementation or implementation science to address these gaps and to make sure that research findings are being implemented into practice. At the Joanna Briggs Institute, we define evidence implementation as a purposeful and enabling set of activities designed to engage key stakeholders with research evidence to inform decision-making and generate sustained improvement in the quality of healthcare delivery. And there are three key elements of evidence implementation. The first is a context or situational analysis, and this needs to be done perhaps prior to any change and then throughout the change as well. So you need to consider how ready your organisation is for change or for implementing evidence. The second key element is facilitation. Change or implementation projects do require a facilitator or driver of a change, and often these people are called champions, or they may be project managers, but they really need to drive and lead that change in an engaged process. And finally, evidence implementation includes a process of evaluation. We want to know if any changes or new strategies that we've introduced have actually had some sort of impact on processes or on outcomes. Now, there are many different models and theories that exist for evidence implementation. There are two main ones. The Knowledge to Action Framework, which comes out of the Canadian Institutes for Health Research, which talks about the importance of a systematic review and then the steps to get that evidence into practice. And there's also the Paris Framework by Alison Kitson and her colleagues. I'm not going to be discussing evidence implementation theory in much detail in this talk, but there was a reasonably recent paper published on some of the theories, models and frameworks in the field of evidence implementation, which you may like to refer to if this is an area that interests you. What I do want to focus on today are some of the strategies to promote evidence implementation, and particularly on audit and feedback. So there are many strategies that people have used to try to address the issues that I've talked about during our introduction. I'll run through these quickly now. Reminders are one strategy that have been used. These can be either manual or computerized reminders, which are basically prompts to get the healthcare professional to follow what the research evidence says. So prompts that may pop up and inform you of what you should be doing. Audit and feedback, we will discuss a little bit later on, is also a strategy that has been used. Consensus processes, so making sure that you get everyone together in a group to decide the way forward. So these consensus processes have also been used. Using key opinion leaders to spruik your message and the importance of your of change has also been used. And then, of course, there are the various forms of education that have also been used to implement evidence, such as the distribution of educational materials, such as pamphlets and brochures and whatnot, educational outreach, interactive educational meetings as well. Didactic education has also been used and studied. Financial incentives have also been used to encourage people to follow what the research or what standards are, either at an organisational level or at an individual level. And multifaceted interventions, which essentially include one or more than one of these strategies, have also been used to try to get evidence into practice. Jeremy Grimshaw, who is one of the leading researchers in implementation science, has done a lot of research on the effectiveness of some of these strategies. And his conclusion is that our evidence on the effectiveness of these strategies still remains somewhat incomplete. However, what has become clear is that individuals involved in evidence implementation need to identify modifiable and non-modifiable barriers relating to behaviour, identify potential adopters for change and practice environments, and then prioritise which barriers to target. So specifically address barriers and target the barriers to change. So please keep these ideas in mind throughout the rest of this talk. So I want to move on now to discussing clinical audit as a strategy which has been used for evidence implementation, and discuss some of the myths and misunderstandings perhaps around clinical audit. So first, what is a common understanding of audit? And sometimes there is a negative perception of audit as well, both within and outside healthcare. Sometimes this term audit can strike fear and people hear it. And this definition of clinical audit reflects what I would say is the common understanding of audit, that audits are conducted to establish the extent to which clinical practice complies with identified review criteria, or essentially to measure what's going on in a certain setting and to see how it compares with standards or criteria. And this is sometimes a common understanding of audit, and sometimes people are fearful of audits because they're worried about what the results will show, and that it may show that they aren't performing or that they are performing at a subpar level. The definition we prefer here at JBI, and which fits more nicely with evidence implementation, is the definition from the National Institutes for Health and Care Excellence in the UK, where they stress that clinical audit is a quality improvement process that seeks to improve patient care and outcomes. Yes, it does this through a systematic review of care against criteria, just like the previous definition, but it also includes the implementation of change. And this is a type of audit that we'll be discussing today, one that is a quality improvement process and one that is focused on the implementation of change. So not just doing an audit to check practice and see how you're going against standards, but actually as part of a quality improvement initiative. So it's always important to make sure that what we're doing is effective. And there has been a Cochrane review, which was published in 2012, which evaluated the effectiveness of audit and feedback audit and feedback as an evidence implementation strategy. It included 140 studies, and it found that there were generally small to moderate effects, normally leading to improvements in practices and processes following audit and feedback. However, there was a lot of variance in the results, and this was due to things such as baseline compliance. So compliance initially, the intensity of interventions, whether audit and feedback was done as part of a multifaceted intervention, and also the methodological quality of the studies as well. So what they found in this systematic review was that there were larger improvements or larger effects were seen where baseline compliance was low. So areas where there was poor compliance or poor practice currently, these areas where there was a audit and feedback process initiated often had greater improvement than those which had moderate to high baseline compliance. And where the source of feedback, so providing that information about the audit results, was a supervisor or a colleague, when the feedback was provided more than once, when feedback was delivered in both verbal and written formats, and where the feedback included explicit targets and an action plan for change or improvement. So these are some of the characteristics of audit and feedback strategies which are more effective than others. So please keep those in mind. So why would you get involved in audit? Why would you actually do an audit? Well, there's a number of reasons. The first, of course, is patient care. First and foremost, we want to improve care and services and outcomes for our patients. There are also professional reasons as well, to develop knowledge and skills of the audit team, but also people across the organisation, and to improve teamwork and accountability within the organisation. There may be political reasons as well, and there may be that the audits are imposed on people. People are told they need to do an audit, and if this is the case, we need to make sure we are doing the audit in a correct way. So how should audit and feedback projects be initiated? Well, they need to be led, professionally led, and hopefully they need to include someone who is a facilitator of a project, someone who'll be a champion for that project and lead the change. The facilitator should involve everyone who should be involved in that project, be encouraging throughout the project, and really drive the importance of that change. And facilitators and good facilitators are really important for good audit and feedback programs. Audit should be seen as part of the educational process, so an opportunity to learn about what we're currently doing and how we might improve. Audit should also be routine as well. So audit should form a part of routine clinical practice. Often in many organisations and many settings, audits aren't seen as routine practice, and what happens is that when people hear of an audit or perhaps an accreditation activity coming up, which might happen once a year or once every 2 or more years, then all practice is suddenly changed for that period of that audit, as people prepare for the audit and for perhaps that accreditation activity. But as soon as that's done, because it's not routine, then everything just returns to normal. So we need to make sure that audit is part of the routine clinical practice. Audit criteria and standards should be based on the research evidence, and make sure that we are including the results of high quality research as much as possible in these standards. And of course, once again, audit and feedback should generate results that can be used to improve patient care outcomes. So what topic, when deciding to do an audit and feedback program, what topics may you consider to do for your audit and feedback? Well, here are some indications for audits and to assist in the choice of a area or a topic to do your audit and feedback. High volume interventions are always good to address. So these are interventions that are delivered frequently, or patient scenarios that are encountered commonly, and these are always good areas to start off with, because they're likely to have the biggest impact in terms of outcomes and costs as well. You may choose to do audits and feedback projects in areas which do have a high cost or significance as well. You also want to do audits and feedback programs where there is an availability of evidence, hopefully high quality evidence or guidelines. So it's very clear, it needs to be very clear exactly what you should be doing for these projects. It may be based on a national request or a local request. And of course, it needs to be in an area that can be influenced or that can be changed. You want to make sure that you're doing the audit and feedback project in an area which it is actually possible to make a change and an improvement, and an area where it is possible to also sustain that improvement as well. So it's important to convey that audit is not a measure of satisfactory progress for staff training. If you're doing staff training, then you should consider some other sort of evaluation process, not necessarily an audit, to determine if staff have retained their knowledge from that training program. Audit shouldn't be seen as a performance appraisal or a disciplinary mechanism. And this is often the case with audit. As I mentioned before, sometimes there is a negative perception of audit, and it is because people do see it as an appraisal of their performance or as a disciplinary mechanism. And if this is the case, then there will always be a negative attitude towards audit. So it's important that, and this is also why feedback and transparency during the audit is so important, that people don't feel fearful of the audit process. It's also important to state that audit is not actually research. Although audit and research are similar in some of their data collection and analysis methods, they are not actually the same. So I just wanted to quickly touch on this point. So we perform research because we want to answer a question, and we don't have information available about that question. And we do research with the aim of then establishing what best practice is and answering a question. And during the research process, new knowledge is generated. And this can, depending on the research we're doing, this research or these findings from this research can be replicated and applied to other groups. We also may do research, of course, to confirm best practice. And research is often part of a one-off study and is driven by researchers. Now, if we contrast this with audit, when we are doing audits, we have the information available. We know what best practice is. What we're actually trying to find out is whether we are following best practice. So in audit, we are measuring practice and comparing it to the best information. And we're trying to focus on a change in practice. Audit is therefore linked to one patient group or location, and the findings of audit projects aren't considered transferable normally. The aim is to improve your service, and audit should be an ongoing process or a cyclical process, and it's normally led by service providers rather than academics or researchers. So this schematic shows the various stages of clinical audit. The first stage, where the star is where you select your topic, and I've talked about some of the indications for topic selection for clinical audits previously. Then you need to plan your audit in detail and make sure that you have your evidence-based criteria that you will be comparing against. Make sure that you are clear on all of your data collection methods, and you should follow some sort of protocol for all of this. You then compare and monitor your practice against these standards. This is what we call the baseline audit, or the first audit. Once you have the results of this audit, you then need to look at where your gaps are, where your areas for improvement are, and identify what the barriers are to those improvements. You then need to take action to improve practice and target those barriers, and then do a follow-up audit or a re-audit as well to see if you have actually improved your compliance. Now, as I mentioned earlier, audit is a cyclical process. So once you've done your follow-up audit, and if you're still not compliant, or if you still feel there is areas that need to be improved upon, then once again you follow this process where you take your action to improve practice and perform your follow-up audits. So successful auditing will be done by a team. So it shouldn't be done just by one person. It should be done by a team. A multidisciplinary team is preferred, and it needs to have managerial support or executive support. there needs to be necessary resources and structures in place. People need to be allocated time to do the audits. We don't want to overburden people and just lump them with doing an audit. We want to make sure that we give them dedicated time and resources to do these audits. There should be training and data collection methods and the importance of audit and feedback. Communication and feedback is important throughout the whole process. Where possible and when the topic warrants it, patients and consumers can be involved as well. Motivation is an important component of change, and this is often where the facilitator will come in to make sure they are driving that change and motivating people. And it should be cyclical as well. So it shouldn't be one-off, it should be an ongoing process. And successful feedback, as we've seen from the Cochrane Review, can have a huge impact on whether or not the audit is successful. So feedback is very important. It's important that positive outcomes are highlighted and also areas for improvement are highlighted. The more feedback, the better. And feedback can be done in multiple formats. It can be done in verbally, through meetings, through lectures, through in-services, etc. It can be printed through posters, memos, and it can be electronic as well. So it can also be sent around via email and whatnot. But transparency is key with audits. Where possible, it's always important to be as transparent as possible that the audit is going on, and that it is not going to be used as a disciplinary mechanism. So let's discuss some real-world examples of audit and feedback projects which were done with an evidence implementation focus in mind, so which are actually done to improve practice. The first one I want to discuss is an organisational-wide example, and then I want to discuss a smaller scale audit if we have time as well, which was done on a unit level. So quickly, I just want to talk about a large audit which focused on medication administration practices across the Central Adelaide Local Health Network, which is composed of a number of facilities, the largest being the Royal Adelaide Hospital and the Queen Elizabeth Hospital here in South Australia, and a number of services as well. And across the network, there's approximately 13,500 staff. And as I said, the Royal Adelaide Hospital and the Queen Elizabeth Hospital are some of the major hubs within this network. And a topic chosen for an audit and feedback project was medication error, medication administration, because it was identified by a working group, a multidisciplinary working group, that medication error was one of the most common types of adverse events experienced in hospitals. And the Commission on Safety and Quality in Healthcare had published standards that healthcare services needed to adopt, and one of these standards focused on medication safety. And so this standard, so the Central Adelaide Local Health Network wanted to address this standard through an audit and feedback project. And data from the Royal Adelaide Hospital actually showed that a lot of medication incidents and errors essentially were occurring during the administration process of medication, which is why this topic was chosen. So it was a high volume area. So there are 8 evidence-based criteria that which were the audit criteria for the project, which essentially were going to be compared to practice to see if people were following these criteria in practice. Now, this was a very large audit. It was done across what's called the 7 directorates of the Central Adelaide Local Health Network, and across the different sites as well, so across the different hospitals and services. So in total, there was 102 distinct data collection sites, and 16,000 observations or measures of practice were collected. So although the audit and feedback was the main strategy used within this project, in fact, it was a multifaceted implementation strategy, which and consensus processes, opinion leaders, and education were all part of that audit and feedback project. So training was done across the organisation, and key champions in each site were identified, who were essentially responsible for the audit and for driving change in their area. And a lot of training. There was a lot of engagement across the whole service with these champions as well. And it was important to also provide feedback to everyone within the organisation, all staff within the organisation, about this project. This has been published. The results of this project have been published, and what was found was that for all 8 criteria, there was an improvement in compliance. So practice did actually improve throughout this audit and feedback project, statistically significantly so in 6 of the 8 criteria. And just showing you one example of one of the services that was included in this project, the South Australian Prison Health Service. You can see here the baseline results in the brown and the follow-up results in the aqua. You can see here just how practice did improve from that first audit, and then after the implementation strategies in the second audit, how practice really did improve. So what were some of the reasons for success for this audit? Well, it was an organisation-wide audit, which meant that there was able to be some benchmarking against other areas, and this led to a sort of competitive spirit across some of the units, as they wanted to make sure that they were doing well compared to their colleagues. There was training rolled out across the whole organisation, so there was a lot of training of champions and auditors and general staff as well about evidence-based healthcare, evidence implementation, audit and feedback, and medication administration as well. We made sure that we did a lot of feedback, and we did this through some very large lecture theatre style presentations, but also through a lot of group meetings at a unit level, and also through posters and email as well. All of the training materials were put on the intranet, so everyone had access to them. All staff within the organisation had access to them and could go and find what they were looking for relating to this project very quickly online. It had a project manager, which was very useful to keep everyone on track. And the champions and facilitators of change really drove all of the improvements. Very importantly, there was executive support and leadership as well, and that really helped to have that top-down support. So very quickly, because I know I'm starting to run out of time, the second example is a smaller scale audit. So audits can be done on that large scale, multi-site, organisational wide level, but they can also be done to improve practice in a smaller scale, say in just a ward or just a smaller facility as well. And this is an example about improving assessment and management of delirium in an orthopaedic surgical unit. The methods used were the development of evidence-based criteria. Then once again, similar to a previous project, there was a baseline audit to establish compliance, a situational analysis to identify barriers, then develop strategies to address these barriers, and then a re-audit to see if there had been improvement. I won't go into the criteria in detail, but they were all on assessment and management of delirium. And what was found was, following some implementation strategies such as meetings, the development and rollout of formal assessment tools, guideline development, and a lot of feedback, was an improvement in compliance with all of the audit criteria as well. Once again, this has been published, so if you're interested in this project, please do. And sorry for rushing through that, but I am conscious of time. So summing up, audit and feedback programs are a proven method of improving clinical care and changing practice when you do take that approach to audit and feedback, that it isn't just a way to measure compliance, but it is also a process to implement change. And if it is a process to implement change, then it does need to include situational analysis, identification of barriers, action planning and taking actions to address those barriers, making sure there is engagement and feedback across the organisation or the area where the audit is being conducted, and that is a cyclical process which aims for sustainable improvements. So I'd just like to finish up there, and once again, just very quickly plug our conference, which is later on in the year, celebrating our 20th anniversary here in Adelaide at the National Wine Centre. If you have any questions or you want to ask me any questions after this, please feel free to email me at my email address there, and also please feel free to go to our webpage at joannabriggs.org for information on any of our training courses. But I'll finish up there and open it up to questions.
Thanks, Zach. There's a couple of questions online. One from Emma Power, who asks, was follow-up assessment audit conducted, i.e. how long was the intervention effective for? How were the successes identified? How were the successes identified, determined? What implementation methods were used? How do you know? And how do you decide? I can't understand that last bit. I'm sorry. How do you decide ANF was critical ingredient when it was multifaceted? Might mean.
Okay, all right. I presume these questions are relating to the example project. I hope they are anyway, because that's what I'm going to address. So yes, so it is the results that I presented were from the baseline and the follow-up cycle, and because there was a high compliance, firstly in the baseline and in the follow-up cycle, what the project group decided to do was an annual audit rather than doing it at a more intense frequency. And I'm sorry, I don't have the results whether or not that practice level was maintained because it was quite a recent project. So I can't give you a final answer on that. How were the successes identified? The implementation methods which were used, as I said, for this project were audit and feedback, and then a lot of education. And there was also a process, once those baseline results were available, they were presented to everyone, and then at a unit level, because that's where a lot of the change occurs, the units brainstormed what they needed to do to address the areas for improvement. So in some areas, for example, one of the criteria was about making sure you check that it is the right patient that you're administering it to by asking their name and date of birth. And one of the barriers was that patients were getting frustrated with always being asked all the time about for their name and date of birth. So what some of the units did was create posters which could go in the patient rooms and throughout the unit, which talked about the importance and why they were always being asked their name and their date of birth before being given medication. And this was one of the strategies that was used. How do you decide audit and feedback was a critical ingredient when it was multifaceted? Well, we can't pull out audit and feedback, and from the research from the project we did, we can't say that the improvement was just due to the audit, the collection of data, or just due to the feedback, because as you say, it was multifaceted. But what we found was that the whole bundle did actually result in improved compliance. Okay.
There's a couple more. Lisa Sharwood, did you mention an optimal time period following intervention within which to re-audit?
No, I didn't, and that's a very good question. So that's often going to be a question that your group need to consider, and then there is different guidance about when you should be doing your re-audits, and there are a few different considerations. So first off, you need to consider how long is it going to take for you to come up with some strategies to address your areas for improvement, and whether or not that will take, whether or not you have enough, you need to have enough time to do that process. You need to have enough time to come up with those strategies and then implement those strategies, and for those strategies to have an effect as well. So normally, you know, it's probably around that sort of 6 months time period or thereabouts, where you have enough time to come up with those strategies, implement them in practice, let them have an effect before you do your re-audit. Now, any subsequent audits after that, that's really a decision which is up to the project group. So if you find that in your follow-up audits you're getting, you know, between 90 and 100% compliance, you may say, well, it looks like we're doing very well in this area already. It looks like our practice is quite consistent, and it seems like it is being sustained. So perhaps we don't need to do a re-audit or follow-up cycles quite frequently. However, if what you find is that you're doing terribly in a certain area, you may decide that we need to do more re-audits. We need to do this quickly. We need to make sure that we are improving this process. So you might choose to do it. To do that more frequently. So there is no optimal time. It really depends on what your results are and what's going on in your setting.
Okay, and Lisa had a follow-up question. If you conduct an audit of a convenience sample reporting current practice, do you then have to re-audit the same clinicians or just the same practice area?
It's up to you, but what happens normally, because clinicians are often change over time, is that you just do the same setting, so the same hospital or the same ward or the same unit, rather than the actual same clinicians. Yeah.
Similar question: how important is it to involve clinicians who you hope to change in setting the criteria for the audit?
It's very important. It's very important that you engage with people who will be affected by the audit, and with all key stakeholders as well. We know that sometimes there are people who are very resistant to change and can be a barrier to that change. And sometimes by including them within the whole process, you can sort of address this right from the start, and then instead of being a barrier, they can actually help facilitate that change. So it's very important to involve clinicians and to provide as much feedback as possible throughout the whole process with everyone affected by the audit.
And there's just a final question from Catherine Nelson. As part of developing the audit tool, did you capture material on modifiable and non-modifiable areas?
That's a very good question. So one of the approaches is, as Jeremy Grimshaw said, to identify modifiable and non-modifiable barriers or areas for improvement. And some of them will be modifiable. And as you say, Catherine, some of them won't be modifiable. So you won't always be able to say, if a barrier is that there's a lack of staff, you won't always be able to employ or assign more staff to that setting, depending on your context or resource. So it's important to highlight those or non-modifiable areas in your audit. But yes, you can't always address all the barriers, unfortunately.
Okay, that looks like the end of the questions. Thanks very much, Zach. Zach's slides will be available on our website in a day or two, and we've also recorded the presentation, and that should be up in a day or two as well. And you should get a follow-up email with details of how to access both of those. And as Zach said, he's happy to take any questions by email if you have any follow-up questions. Thanks, Zach.